So without further ado, I'd love to welcome you all once again to today's webinar and introduce today's speaker. So the topic of today's webinar is navigating insurance with chronic conditions. We're pleased to have Elizabeth Johnson join us today to share tips for working with insurance companies. We know this can be a challenge with chronic illness, such as eosinophilic disorders, that require lots of doctor's visits, procedures, treatments, and supplies. Elizabeth started her career in allergy and immunology and fell in love with the challenge of specialty medication access. Currently, she's the Chief Executive Officer for MedicoCX and the co-founder and president of the National Association of Medication Access and Patient Advocacy. Elizabeth is a licensed practical nurse with a rich background in patient care and holds multiple certificates. Welcome, Elizabeth.
Hey, thanks for having me. I appreciate it.
Absolutely. Well, the show is all yours.
All right. And you can see my screen, correct?
That is correct.
All right. Well, hello, everyone. It is nice to see some familiar names and faces on here. I appreciate the opportunity to talk about this specific discussion. I have been in and around healthcare for a little over 10 years, and insurance is a puzzle that I can't seem to stop trying to figure out. And just when I think I understand coverage or the bits and pieces, something changes and I'm continuously learning. So just some quick things that I'm going to highlight in this is overview of insurance coverage types and kind of what that means for you as a healthcare worker, your patients, or if you are a patient, what you are maybe up against, and how to prepare for when you go to see a provider or need a specialty medication. Some coverage tips, what to look out for, what is Medicare, which could be an entire discussion all by itself, but I'll hit some highlights there for some understanding. Some extra programs that are available, and then how to be your own advocate. I think that's the biggest point today is how you can communicate with insurance and with your provider to make that process go a little bit smoother. So there's me. I have a lot of acronyms after my name, or alphabet soup, as we call it. In short, everything that I do and every certification that I have was to help me better understand the process. So how I can work with patients, how I can understand what a patient may need, such as billing and coding, as well as advocacy. So I've done a few things through that process. I have a day job at MedicoCX, which is a physician purchasing group, and I get to help physicians and their staff with specialty medications. But then I get to have my passion project, which is NAMAPA, or the National Association of Medication Access and Patient Advocacy. And to kind of explain what NAMAPA is, I have always been patient-facing. I have always done everything I could on behalf of my patients. But what I realize is if I can help the process and I can help a patient a little bit sooner in the process, that's where I want to focus my efforts. So my version of patient advocacy is helping healthcare workers from the time script is written until the patient gets that medication. So things like today, talking about insurance, as well as other tips, tricks, organization, of offices, of hospital systems and things like that. So my stab at advocacy is towards healthcare workers to benefit the patients. It is a 501c3 nonprofit. We work with other 501c3s and our other nonprofit organizations partnering to all deliver the same message: patients come first. So some important terms, and this is something that through putting this entire presentation together and really thinking about what this message for today would be, is I could use acronyms, I can use these terms, but without proper understanding of them, I'm just going to lose everyone in the weeds. And I will start this out by saying this isn't on here, but the thing that to keep in mind this entire thing, and even in your journey as a patient, is that we're all a healthcare team. There's a lot of situations that come up where it's like the doctor versus the insurance company versus the doctor or the patient. But at the end of the day, we're all working together, maybe a little bumpy, but we're all here to do it for the patient. So I am maybe petty, if you want to call it, or a pleasant reminder that when I'm working with an insurance company or I'm working as an advocate with a provider, is that, hey, we're all on the same team here. So with that, Some things to keep in mind for these terms: out of pocket. We refer to that as money that's coming from the patient. And a lot of things can contribute to the term out of pocket, but in general, it's how much money put out by the patient. Premiums. When we're talking about insurance, we hear deductible, which is next on that list, and we hear about how much the patient's going to have to pay. But we always need to keep in mind what that premium is, that monthly cost to that patient, because that compounds on what's coming out for out of pocket or deductible. And depending on what type of insurance you have, depends on whether you're paying a lot, so having a higher premium, or maybe an employer covers some, or it's government insurance. Copay, fee or predetermined amount that has to be paid. And copay can actually range, right? You've got coinsurance, which is next, which is a percentage, but copays can be a percentage, or typically that $20, $50, so on. But there's copay cards, there's copay assistance. We kind of throw that word copay around to kind of all encompass anything a patient has to pay. Network, knowing whether your provider is in network or out of network. I think we've all heard at this point some story of someone going to a hospital, maybe going to the ER, a physician sees them, but the physician wasn't in network, but the radiologist for an X-ray was, and having to fight escalated or higher fees due to that in-network and out-of-network status. What it comes down to is contracting and what payer they are with. An HSA, this is a great way if you know you're going to have out-of-pocket costs, right? These are pre-tax dollars going into a savings account that allows you to spend them on healthcare related fees. So an HSA is a great option if you know that maybe your income is high, so you don't qualify for certain assistance, or if you're going to be needing a procedure, something that you can't have assistance for, to save for that. On the other side of it, a lot of people have FSAs, or a flexible spending account, and those have to be used by a certain time, the end of the year, where an HSA continues on. And the other important part is place of service. Everything you do, every service you have, whether you see a doctor, have surgery, have a test done, they're done at a place, and that place matters when it comes to contracting. So having something done at an outpatient surgery center versus in a hospital could dramatically impact how much that cost is. My favorite part, my background is especially with the pharmacy side and medications. There are lots of different types of pharmacies. Most commonly, you think of your, Walgreens, Rite Aid, whatever's around the corner, right? You take your script, you fill it. There's actually different types of retail pharmacies. There are mail order pharmacies, and there are specialty pharmacies. Mail order and specialty can sometimes overlap. But typically mail order is sending you your 90-day scripts worth, could be any medication, blood pressure, cholesterol, things like that. A specialty pharmacy, I think special as in special handling, typically cold storage, overnight shipping, things like that. Copay assistance. There are lots of different types of copay assistance. Remember, I said it kind of buckets together a lot of those different things, but there can be copay cards. And those can be broken down into actual debit cards, coupons, things like that. Patient assistance programs, those can be free medications. Those can be grants or other forms, as well as compassionate use. If you're not familiar with compassionate use, it does not get used all the time. These are typically programs that take the applications are just phenomenally long. But manufacturers of medications do offer these programs for off-label use. So if you have a condition that is being treated with, I'm not going to name meds today, but a certain medication, and it just won't be covered by your insurance, there is the ability to apply for compassionate use. But I warn you, and we'll talk about this later, the documentation, what is needed from you as the patient, but also from your healthcare provider, is extensive. So those programs are phenomenal. I'm glad they exist. They're just a lot of work, warning there. And then pre-service review. And this is where I think we lose a lot of momentum in the process. Pre-service review, most people have heard of a prior authorization, but there's actually a lot of other steps in that. And I really love to break down that part of the process because that's where time ends up sitting, especially in the specialty medication world. If you're having to get your benefits checked, right, and we'll go over benefits for insurance, look for copay assistance, do a prior authorization. Some of those can happen in a day. Sometimes it takes a month or more. So that whole pre-service accompanying everything that goes into you getting your treatment or procedure, a lot happens there. So where does insurance come from, right? There's lots of places insurance comes from, and knowing what kind of plan you have or where you got yours can really help your provider. So everyone's kind of heard of the Affordable Care Act and Marketplace and Medicare, but there's actually a little bit more to break down there. So you can say, hey, I need insurance, and you can go directly to a major payer, your Aetna's, United's, Cigna's, and you can go buy your own health insurance. You can call a broker. They can shop plans for you and say, I think this one looks best. Here's what it costs. Do you want that? So you can completely do that. Your employer may offer insurance. And if not, you can always inquire. There are different rules about employers offering insurance and how much they cover, but never hurts to ask your HR department, or if you work for a smaller organization, do they offer a stipend to cover part of your premium if you have to purchase on your own? There's lots of different ways employer insurance can work. There's also, from my side on the healthcare side, there's also regulations that come in with employer-based insurance that can carve out medications to one specific pharmacy. There can be other rules that we have to follow. So I typically, from the healthcare side, when I'm working with a patient, hey, I have United Healthcare. Okay, it's great. Can I see your card? I'm looking for employer logos. I'm looking for other things on the insurance card that will help me determine if that's an employer-sponsored plan. The Marketplace, back to the Affordable Care Act, you can go onto the website and search through the Marketplace, healthcare.gov, and see what plans. There are certain times of the year that is open. There are other times that you can opt in to look for insurance there. There's all different levels of coverage, and you can use tax credits and other things to help cover those cost of premiums. If you don't understand insurance or you have questions, I strongly recommend reaching out to any sort of assistance. They have links, contact us here and all that for some explanation, so that you get the plan that's going to fit you best, not just, hey, that looks great, I'll take that one. For government insurance, Medicare is typically for 65 and older. There are other cases where individuals younger than 65 are on Medicare. Just because you see it, you should always check. Age doesn't matter. What's going on, what's the coverage, so on and so forth. Medicaid, state issued. I tend to, most of my advice and most of my chatting with practices is in the Medicare Medicaid combo. So, and that typically is a lot of individuals under 65 that have that. And so navigating the challenges and access around those. But each state is different, and each state can have multiple different types of Medicaid. So some are partnered with local payers or Blue Crosses, United Healthcare's, and some are offered directly from the state. So if you are not familiar with your state's Medicaid plans or plan, it's a great place to start researching, especially if you're on the healthcare side. I learned a lot when I first started working with a practice in Indiana, and they had 9 different types of Medicaid. Things have probably changed since then. I don't know the exact number anymore, but that was my first interaction with multiple types of plans. And then TRICARE. TRICARE for military, whether they're active duty, prime or standard, if they are retired, TRICARE for life, for Medicare beneficiaries, knowing what those different types are. A lot of confusion we hear is for government workers, and they'll have a plan that it looks like it says government on there, or it looks like it may be military based, but it's actually a commercial plan. So understanding the difference in active duty or TRICARE standard and government health there. And then health sharing. I don't typically see a lot of this, but I do bring it up. Typically, these are faith-based. And the way this works is that you pay into a group setting. And when you need healthcare, or anyone in your group needs healthcare, they go out to get what they need and then come back, and it comes from that fund or that group or that pile of money that's in that program. Typically, those are somewhat difficult to work with when I'm trying to get specialty medications. There's other resources available just because of the type of insurance that is. But I do notice when I look up health sharing plans, There are some new ones that are coming out that are not from a faith-based background, but looking to kind of change the insurance landscape, I guess, especially for those that can't afford some of these other plans. So when you get insurance, there are two main benefits that come with your insurance. And pharmacy benefit, which I'll talk about in a second, isn't always on there. So when you're enrolling in a plan, you really need to know what you're getting, right? So most people are familiar with the medical benefit, or you hear major medical. And this is what covers your physician or provider services. This can be used for medications given by a provider in a facility or in their office. This is where your deductible really takes place, right? So costs associated go toward the deductible there. And that can be through various ways. Co-insurance, and we'll look at some scenarios here in a minute of how that deductible can be eaten up or how it can be used. But knowing what type of plan that you have, whether you pay $5 every time you go, or you've got an 80-20 split, right? So you pay 80%, insurance covers 20. That's how you calculate out how much you've spent and what's gone towards that deductible. Most now have portals or apps or things you can log into. If you're ever curious how close you are to meeting that deductible, say you find out you need surgery or you're going to need to see a new physician, you can get on there and take a look and kind of, they usually have these cost estimators and things like that. You can kind of play around to give yourself a better scope. You can also always call your provider and say, hey, I'm struggling. Can you help me with this? I get it. We are all short-staffed and we are all busy. But truly, if you want to know or ask, starting with a provider you are familiar with is a great place to start. On the pharmacy side, so separate benefits, different structure. Pharmacies have different contracts. It's not just like, hey, Blue Cross, I have a pharmacy plan through you. They may work with what's called a PBM or a pharmacy benefit manager. The deductible is separate typically. And it follows a different system. It can be tiers, right? Tier 1 through 5, 1 through 4, and have a specific cost associated with that tier, or it may be a percentage. But it all starts with if it's on formulary or not. And different plans have different preferred formularies. So a drug you may have been on for 5 years, you change insurance, and it's no longer on that formulary. So you may have to change, or your provider may have to ask for an exception. There can be exceptions as well. Say you have eaten up your pharmacy benefit or it's not covered there. Certain insurances will allow you to do what's called an AOB, or assignment of benefits, and change from the pharmacy benefit to the medical and vice versa. It's not super common, but it does happen. And then when you're looking at cost and you're looking at what your coverage has, what is the best way to get your prescription medications? Is it going to pick it up at your local, on the corner pharmacy? Is mail order the best way to do it? Or does it come from a specialty pharmacy? I've noticed with my own prescriptions that mail order is the way to go for me. My copay card that I get with my prescription covers a 90-day supply. So I pay the same amount for 90 days that I would pay for 30 if I picked it up here locally. So knowing those things, you'll probably get a letter in the mail. Most recently, I posted something on LinkedIn about a pharmacy survey I received about a prescription, a 90-day dispensed prescription I had from 2020. I don't remember. I know I got it, but I don't remember any details. But I thought it was interesting because the cost associated was a lot higher than what I paid. So I'm very thankful for copay cards in that situation. This is a terrible version of an insurance card that I made myself, but it highlights the important information on there. So going back to, hey, I need to see your insurance card so that I understand what I'm looking for. This one has the insurance number ID at the top. The ID can be anywhere on the card, as well as any group numbers or any other affiliate numbers. The subscriber name, sometimes it lists all the dependents on there. Great when you can see everyone at once. Really confusing if people have the same names. I know in my family, my husband and my son have the same name, so date of birth is incredibly important. If there's a pharmacy benefit manager that's on there, the type of plan, as well as PPO, things like that. So that's commercial insurance we've talked about, right? That's what most commonly we see, but that's shifting, right? We've got an aging population. We have more Medicare beneficiaries than we've ever had. So understanding Medicare, or if you're at the part where you're about to transition into Medicare, having a high level knowledge of this insurance is extremely important. And then for my healthcare friends, this topic, I feel like it takes us forever to understand it. And once we do, again, it changes. But this is where the core of the content and learning that I like to focus on. So there are 4 main parts of Medicare: A, B, C, and D. And this took me forever to understand, especially Part C. But A is your hospital. B is your medical insurance, so that major medical or provider covered insurance. C is a Medicare Advantage. So it is everything wrapped up into one. And then Part D is your prescription drug coverage. What are your Medicare choices? And this is actually pulled from Health and Human Services, but this is a great slide to go through and kind of see what you would need. And one of the best pieces of advice that I've ever gotten when speaking about Medicare is from a pharmacist that I'm acquainted with, Geraldine Arneson. And she's helped me actually enroll my parents on Medicare. But what are you looking at when you're applying? And it's not today, it's not tomorrow, but where's your health going? What current conditions do you have that could impact your health in the immediate term and in the long term? When you're enrolling, you've got that first 6 months to get into a supplement or into these plans without having to go through underwriting. And this is really important in that you want to make sure you set your patients up for long-term success. I'm not an insurance broker. I'm not a benefits counselor. We all know that patients come to us in the healthcare side and say, hey, I'm about to go on Medicare. What should I get? And my best advice is, one, contact a benefits counselor or go to your senior services and ask that question. But I always give the same piece of advice. Think long-term. Yes, I know a Medicare Advantage plan may seem great. I'm sure you've seen a green tent in the Walmart parking lot and somebody has been out there trying to hunt you down to sign up for something. I'm sure, but you need to do what's best for you. Think 10, 20, 30 years in advance. So this is a great little kind of flow chart to go through and see what coverage would probably be best. Prescription drug coverage. Most times these are run by private insurance companies. Many Medicare Advantage plans, so that type C, include pharmacy or Part D already. There's no pre-existing condition clause. And every plan has a different formulary, cost structure, and preferred pharmacies. So it's the time of year right now where we call the blizzard. And it's beginning of the year, insurances have changed over, formularies have changed, policies have changed. And so looking at patients and renewing them on their prescriptions, it's been a challenging month so far, and that so many formularies have changed. And so we've been scrambling, trying to find the right things for our patients. But I will say, I really appreciate when a pharmacy has their formulary or an insurance company has their preferred drugs on their website. So Part C, Medicare Advantage, this is that combo, right? Everything's kind of wrapped up into one for the patients. And they're usually run by a private insurance company. So they follow the in-network, out-of-network. They can have deductibles, all the different things, just like a commercial insurance, but a little bit of different in there. Sometimes you have dental, hearing, and vision tied up in it, and it varies, right? You still pay the same thing you would for traditional red, white, and blue, A or B, but it comes out of your Social Security check there. So there is a limit on out-of-pocket costs, thankfully. So we talked about A through D, but there's also what's called supplement or Medigap plans. And this is an additional plan that attaches to your A, B, and D to help cover additional costs. Trying to break that down in the simplest terms, Medicare A and B by itself covers 80%, but there's still a 20% cost. So this is what a supplement plan would pick up, is that 20%. When we're looking at patients who are on infusions, who take medications that go under that medical benefit or that Part B in this Medicare case, the supplements are a great solution for helping cover those costs. So patients who enroll in this, hey, that's great. Patients who are curious, we explain that difference. But this definitely helps pick up that additional. And there's a wide range of them, depending on what the patient can afford and depending on what's available in that patient's area. So they're letters as well. And I always make a joke about how, like, LMNOP all the way down, but plans F and G, M, and there are other ones. So when you're looking at costs when considering care, and you have, depending on the type of insurance you have, this is what I always start with. So I start at, what's my deductible, right? As an individual and as a family, there can be more than one deductible on an insurance plan for your max out of pocket. So I always look at where we are, and real life scenarios. The year I had my son, my husband also needed surgery. So where are we at our deductible? And at that time I had a $10,000 deductible. So it was pretty high for us. So looking at that, and then what's his surgery cost going to be? Do I have a copay for what facility I use, or a co-insurance? What's my max out of pocket? My deductible was $10,000. My max out of pocket was $16,000. And so, crunching numbers and all that. And then depending on the type of service, so is it a surgery? Is it medication? Is there any patient assistance? Working with hospitals, say it is a procedure. What happens after the fact, after services are rendered? Are there payment plans available? Things like that. Or are there charity care cases, right? Can I have a reduced cost because of my income or my coverage? So always great questions to ask there. If I'm looking at pharmacy coverage, so I've seen the doctor, medical deductible, I understand where I am there, but say I've never filled a script that year. What is my pharmacy coverage? I like to be proactive and look up when my doctor says, hey, I want you on this medication. I like to immediately, and I don't want to be a Google MD, right? I don't want to be the person that gets the wrong info, or WebMDs or anything like that. But I look up what my plan is and what may be on that formulary. I'm very pro communication ahead of time. So if I know it's not on there, or I know it's going to be too expensive, I'm immediately asking about copay assistance. Is there a copay card? Is there a generic? Is there an alternative? So that's where I start. And then, is there any savings by doing a 90-day script versus a 30-day script? Now with antibiotics and things like that, that's not an option for an acute issue or a short-term issue. But for chronic conditions, medications I'm going to be on a long time, those are the questions I start asking. So here's just one scenario to kind of look at, kind of put all these pieces and parts together. I love the movie Talladega Nights. So Ricky Bobby is always the patient name I choose, but he visits his primary care and needs a pharmacy benefit medication, right? So his benefits, he's got a $5,000 individual deductible, an $8,500 family deductible on his medical side, a $20 copay for his primary care, and then a $50 copay for specialists. Pharmacies are in a tier 1 to 5, $0 to $100. So physician visit allowable, $300, pays his specialist copay, prescribes a medication, right? Very expensive for 30 days at retail, or he can pay the same price at a 90-day mail order. And then there's a copay card to cover 30 or 90 days. This is a lot of info. These slides will be available afterwards as well. So his medical deductible goes down to $4,700 because the allowable was $300. And then his pharmacy, he does a 90-day mail order with a copay card for $25. So he's eaten a little bit of his medical deductible, but he's also saved a bunch on that retail prescription because of doing mail order plus using a copay card. And scenario 2, which is my wheelhouse that I work in mostly, is a patient visits a specialist, and I used Melissa Johnson in this case, and needs medication provided by her physician. So this would be an in-office administration that would go under the medical benefit. So not even having to touch that pharmacy side. And truth be told, there's a lot more ins and outs to this as far as the coding and billing side of it, but I tried to keep this very high level. And what it comes down to is after, the physician visit, after a few administrations plus copay card or copay assistance, after about 3 infusions, this patient has met their deductible. So they are now covered 100% for the rest of the year, which is great. If the patient needs anything else or any other kind of care, they're able to go and get that because they're 100% covered. There's also a remaining balance on that copay card. I would love for the patient to use all that was given to them, but I'd rather there be some left over than there not be enough for that patient. In this situation, if the patient did not have funds left over and they still needed to receive treatment and were paying out of pocket, there are other additional resources there. This is when I call my manufacturer or my field reimbursement manager and I say, hey, I have a patient, they're no longer covered, they can't afford it. And we ask what types of foundations and grants may be open. So really rely on your manufacturer partners and your third-party foundation partners as well. So there are some complicating factors, right? I'm going through this pretty quick, talking about insurance and coverage like it's a breeze, like there is not a problem in the world. Well, we all know that's not exactly true. So some complicating factors right now would be copay accumulators. And these are plan types that do not take into account those copay cards and apply them to the patient's deductible. So great for the insurance company. It's almost like they're getting kind of paid twice on these things, which can be a controversial topic, but can be scary for the patient. An off-label diagnosis, right? It's really, really hard to get a medication approved if it's not for the FDA approved indication. It does happen for those of you who may work in pharmaceuticals that I'm hearing me say this, sorry, but there are certain cases where a patient has a different diagnosis. Step edits, you may be prescribed something or you may need a procedure and you haven't done the steps beforehand. On the procedure side, we see things like physical therapy, occupational therapy before you can have a surgery. On medications, it may be something over the counter, it may be other prescriptions, and that can be tough. That goes back to cost. If you need certain prescriptions, even over the counter, and you have to pay for those before you can get this other treatment, that can be taxing on a patient, not to mention delaying time. And then income limits, right? Everyone can only afford so much for healthcare. And if I'm asking you to pick up other things, try other things, that's a push. But also maybe you have a great job and you have a higher income, but you don't qualify for assistance. And then the drug is still $5,000. Well, then you don't have accessibility to treatment. So there are other factors on the other side of the spectrum that we do take into account as well. For Medicare, there are some different assistance programs, low income subsidy. This is with limited income and resources to pay for Medicare drugs. And then there's a Medicare savings program. This is where the state helps pay for Medicare costs. Always great to look into what your state has to offer. I have an example, I believe somewhere in here for Virginia, but always look at what your state offers. And this is why with my Medicare patients, one, I refer them to third-party foundations to see if there's something in their disease state open, but also senior services. It's a great place for them to check in with and see what help may be available for them. When in doubt, also send them to the Social Security office. They can help there as well. There's medication assistance for Medicare patients that goes a little bit further, depending on what type of coverage they have. So one part that I tend to struggle with are patients who are Medicare eligible, so they're 65, but they're still working and they have deferred Part B, but have Part A only. And because they're still commercially insured primary, it doesn't quite follow the same in that if they need copay assistance or copay cards. So to my manufacturer partners, that's the first question I always ask when I'm talking about their copay programs is, hey, I know there's a small subset of these patients. Does it cover this? Here's one for Virginia, talking about some patient assistance there. So the best part of this, how can you as a patient and even as a healthcare provider help work with insurance, help work with manufacturers, all these different pieces and parts, right? So in short, be your own advocate, right? You have to own your patient journey. And by own, I don't just mean accept, hey, I have this diagnosis. It's, hey, I've been diagnosed with this. These are my symptoms. This is what's happened to me. This is how it impacts me on a daily basis. But I want someone to know. I want to communicate that to my provider. I want to communicate that to the insurance company. This is why. This is mine, and I'm going to make the best of it. I'm going to be as transparent as possible. And I understand that's not possible for everyone, right? Especially that transparency part. But the way that we can partner and work best together is that communication and that transparency. So record, journal your symptoms. And it doesn't have to be elaborate. It doesn't have to be my right toe hurt at 3 p.m. At 3:15, it was gone. But hey, I have recurrent toe pain and it prevents me from walking to the mailbox. That quality of life aspect is huge. And it's not perfect. It doesn't work every time when we're applying for medications or therapies, but the patient story is the most important. When I'm writing appeals letters or medical necessity letters, it's great from my side. I can put clinical notes in there. I can work with my physicians. But when I reach out to the patient and say, hey, could you help me? A lot of times it's a short letter or not much put together. So the more information you have, the better. The easier you can pull it together, the easier you can send that. Never be afraid to ask any question. I love patient portals. Listen, I'm an advocate. I'm a board certified patient advocate. But when I go to the doctor for a question, I will 100% freeze up and not ask the questions I want to ask. I will have a list on my phone. I will have probably written a list, but I, for some reason, just can't get it out. So what I really love to do is utilize patient portals and send my questions ahead of time. Again, healthcare is overworked, understaffed, and really busy. We all know this, but you're a patient asking for help. Do not be afraid to over communicate and send that question list in. Trying to reach out through there is the best way to start. If your questions, maybe they didn't see it or aren't getting answered, just say, hey, I sent them on the portal. I really want to talk about those kind of things. Be your own advocate. I'm also trying to apply that to my life as well. I think oversharing is caring. I get it, time is limited, but if you're having symptoms and you're having issues, please communicate those to your healthcare provider. And finding the right care team is essential. I know that when it comes to being in network and out of network, you may have limited selection of providers in your area, depending on where you live. Go see them. Wherever financially you can go to, if it takes 5 physicians till you find the right one, I recommend doing so. You want to find a care team that is going to help you. Now, there are some nuances to that and how many visits this, that, and the other can be seen, but I'm going to save that for later and go back to be your own advocate. Very commonly in the pediatrician world, pregnant mothers will go and interview pediatricians before they see them. So it is not uncommon in healthcare to meet and talk with patients and providers. So if you don't feel you're connecting with your provider, please find one that you do. And back to that Google MD thing I said, don't necessarily Google your symptoms and say, I have this. That doesn't always come across well, but you can look up resources, right? The doctor said you may have XYZ diagnosis. Look that up, or you are prescribed this medication. Go look to the manufacturer's website and see what you can find for that. There are things called there are people out there called independent advocates. And these are individuals that if you're not receiving assistance or you have further questions, you can actually go and hire these independent advocates to help you. I love this situation where parents may be older and adult child wants to be involved in care. An independent advocate is a great way to have that additional person help the parent. They can listen in at doctor's appointments, explain things, check on billing if there's a really high hospital bill or provider bill. There's great resources there. They can also point you in the direction of something you may need. Each advocate has their specialty, right? We're not really one size fits all. We all kind of excel in different places. So a great resource to have there. For Medicare patients, there are Medicare benefits counselors. Again, I am not one of those. I do know several, but these are great. So they are certified through the State Health Insurance Assistance Program, and it's free. Medicare beneficiaries can get in touch with those through Senior Services is a great way to find them and really learn more about their coverage and opportunities to them. So that is a lot of information we covered in about 45 minutes. But in here is my email and my LinkedIn. I am always open for questions, comments, feedback, and furthering the discussion. This is super complex, and I wish we could dive into the nuances, but that may be exciting for some and boring for others, and just a lot of information overall. But I'd love to answer questions and chat further. I really appreciate everyone's time today.
Thank you so much, Elizabeth. That was such wonderful information. And I know you said it's a lot, but you presented so many different variations and variables for people to really be able to consider depending on what their personal situation is. So thank you.
Absolutely.
So our first question is about someone who has a child with multiple food allergies. They've run into a situation where people have to have even medications like Tylenol compounded to be able to avoid anaphylaxis. While they have private insurance, they're refusing to cover any compounded meds, even though there is medical documentation that it's necessary. Do you have any tips?
Sure. So first things first is and it's kind of hard because I don't know what all the providers done at this point, but there are for sure medical necessity letters that can be written. There are exceptions that would have to be requested through the insurance. What I would do, because I go back to, I'm a little petty on this, is that I would get my child's medical record. I would write a letter from myself as the parent. Here's what's going on. Here's what our doctor has told us. This is what needs to be done. I'd get my physician to write that same, medical necessity letter, let them submit that to the insurance as the provider. But I, as the mother, would also call. So the patient voice with the payer goes so much further than anyone's. You can prior authorization, state medical necessity. You can ask to speak with a medical director yourself. There are levels of appeal. You can take that way up the chain, all the way to the point where other insurance companies can actually review your case with your insurance company to see if whether they would cover it or not. There are lots of levels to that. But most simply, I'd pick up the phone and call and be the advocate for your child.
We've got another question about medical assistance. And in this case, the person has to take a budesonide slurry for eosinophilic esophagitis. And they're curious if you're aware of any assistance programs for that kind of medication.
No. So it's interesting. Budesonide, the ampules you can get for a nebulizer prescription, at least they're generic, but they get, depending on the formulary, can still be quite expensive. One tip, we had a patient with EOE back in the day that used to go to a DME place. So they had the nebulizers and all that kind of stuff, and they would fill the script through there. And it ended up being cheaper for them there. But I don't know of anything open for EOE right now to help cover that cost, unfortunately.
You talked a little bit about independent advocates. Are they relatively affordable, and where would someone find one?
Absolutely. So there's different pay and different costs for all the different advocates depending on time and what they're doing for you. So Greater National Advocates, they have a website. It was in my presentation. You can actually go on and search all these different advocates registered with this organization based on what needs you have and cost. So it depends, but they are relatively affordable. It's really a time-based thing, almost like a consultant. So definitely explore, definitely ask questions. And I think probably my favorite part of the independent advocate network is that if they can't help or it goes beyond their scope, they will refer you to the next one. And it's a really well-connected community. So you'll be taken care of there.
You have some experience dealing with biologics. And so we've got a question that came in about what information do you need to submit in order to switch from one biologic to another? Do you have any suggestions to help with the approval process?
Yeah, absolutely. So the blatant answer is, trials and failures. But what I really love to do for biologics patients in any kind of specialty medication is I take the payer policy from the insurance company and what the requirements are. I then take my patient's chart and I basically line it up. I make a nice little table in my medical necessity letter. You say you require this, my patient has this. You require this, my patient has this. And then a lot of it goes back to my physicians as well. I am very, very heavy-handed with my physicians in that, hey, listen, your patient is on this specialty med. I want to see that med mentioned in every note. I'm not telling you what to document, but I at least want to see my patient is on X medication, and then tell me, is it working? Is it not working? And why, right? Something short, sweet, but mention it in there. And then I want to see in your plan, is the patient continuing? Are they trying it for 6 more months, or are they stopping it? I can work with whatever the answer is. I just need an answer in there. So if they're switching from one to another, in the assessment part of the note, I want to see this medication is no longer working. I want to change them to this because of whatever the answer is. And then in the plan at the end of that note, I want to see patient changing to this. And that physician documentation, along with a strong letter of medical necessity, makes that change real simple most of the time.
Thank you for laying that out. Some prescriptions or medications are often prescribed off-label, and insurance can sometimes say that they're not going to cover that. Do you have any suggestions for how to go through the appeal process for medications that are prescribed off-label, and kind of what happens or what it might take to get an appeal approved?
Sure. So kind of what I mentioned earlier, right? I always recommend the patient to write a letter, right? Talk about the impact of your symptoms, of your disease state on your everyday life. When your provider is doing an appeal or really pushing for that, your additional documentation, your additional effort, call your insurance company, goes a long way. There are things like compassionate use that if there's just no way it's going to be covered, it's a very different diagnosis than the approval. Engaging in that process is possible, but also look to manufacturer programs. There are some programs that, even if it is off-label, will cover with prescription assistance. So explore those options as well.
Do you find that it takes a certain number of appeals to get something like that approved?
It can. So I think my record of appeals is 4, and I took it to an external appeal where another insurance company reviewed. Typically, I will do the first level of appeal if it requires a peer-to-peer, if they allow a nurse to do it, which is great if I can get in there and help. If not, I'll have my physician do a peer-to-peer. And then if it goes beyond that, it's the physician and I together tackling that. But usually 2 levels of appeal is about as far as I've had to take things.
That's helpful. So you mentioned at one point during your presentation about how sometimes you get a procedure done and some of the people working on the medical team are considered in-network and some are considered out-of-network. Is there anything you can do to plan in advance to be able to know, because you're seeing your provider who's in-network and they set up this care plan, what can you do to prepare before the bills come in and say that you're out-of-network?
Sure. So I tend to joke around that if I ever end up in the emergency room, just somebody ask, are you in network, before you even touch me? Like, just let that be. If hopefully I'm conscious and can say, hey, are you in network? But that's not always possible. So in some situations, you can call back to hospitals or providers and say, hey, no one discussed this with me, or whatever the situation is, that this person was not in network. And you can fight that. Is it 100% effective? No, but at least you made that effort. Secondly, what you can do if it's planned care, right? You're going to an urgent care or you're going to see a new provider, utilize your insurance website and you can look up the providers in your network. So a little homework on your behalf, or calling the provider you're about to see. Hey, listen, is this person in network? Don't be afraid to ask.
You gave a really nice tip for people about ways to use the patient portal to submit questions in advance. If you're working with a provider that doesn't have a patient portal, do you have a recommendation of how to use that same suggestion with submitting questions?
Yeah, absolutely. Write them down, write your questions down. And when you're coming into the office to fill out paperwork, usually in those situations, you still have to fill out, a review of systems or something like that at the appointment. Give that list ahead of time, but definitely write the questions down and have that to give. And if you can't, if you're like me and tend to clam up, you can bring someone with you to that appointment. I know right now in COVID, they're very restrictive on who can come to appointments and all that. But hey, listen, I need this person, or Zoom them in, call them in, and have them, be there as your support to get those questions out.
You also referenced doing some research on the different resources, and not so much like, what do I use to treat this, but what do I know about this once it's been prescribed? Are there specific sites to use over others? You've mentioned a few sites that shouldn't be used. Do you have some that you do recommend?
Yes. So as soon as a provider tells me I'm going on X medication, the first thing I do, if the office doesn't tell me, is I go and look up X drug copay assistance, right? I want to see what's available. Manufacturer websites are great. The patient-facing websites have all kinds of resources and links on there. If it's a diagnosis you're not familiar with, you can certainly put in that diagnosis and then support groups or diagnosis education, and a lot of different resources will come up that way. I always say, be careful, don't fall into the Facebook groups necessarily. You want to go to trusted medical advice. So your mom group next door to talk about X, Y, or Z is probably not the safest place, but organizations, especially disease state focused, such as APFED, is a great place to go to look for more information.
Wonderful. Would you mind sharing a little more detail about the difference between an FSA and an HSA? So many acronyms and different savings plans.
Sure. So an HSA is a health savings account that when you can pull money out pre-tax, right? So before your taxes are taken out of your paycheck, to save for medical expenses. There are different things that qualify for you to spend money on. If your physician writes an over-the-counter prescription for you, take it to the pharmacy, you can use an HSA for it. Little loopholes like that. But at the end of the year, money can stay in that HSA account and roll over for the next year. So you can continue saving. There are limits for how much you can put in them and so on. So make sure you read all of the conditions of an HSA. But on the flip side, a flex spending account, which can be used for other things outside of healthcare, right? So daycare and a couple other things, you have to use all funds in there by the end of the year. So great, same thing, pre-tax dollars, but there are limits still, and it has to be used up. So depending on what your needs are, right? If you know you're on a thyroid medicine, it costs you $5 a month, and you want to go ahead and put $60 in there in your FSA, cool, you will use that by the end of the year. But if you may need a procedure, you're unsure, an HSA so that you can keep saving in there is a better option.
Thank you. We so appreciate your time today and all the information that you shared with us. There's so many intricacies to all navigating insurance, and we just really appreciate it.
Absolutely. Thank you so much for your time, and glad to be able to join.
Absolutely. Thank you also to our education partners for sponsoring today's webinar. Thank you to AstraZeneca, to Bristol Myers Squibb, and to Takeda. We also want to share some information about some upcoming opportunities to be able to continue to stay engaged. You can join our online community at apfed.org/connections. It's a great place to be able to continue the conversation that you started today and be able to connect with other patients and caregivers for support. We also encourage you to check out our podcast. We have a great lineup of different speakers. You can subscribe to us on Apple, Spotify, Audible, and many other places. Our most recent episode featured Dr. David Hill. We had a great conversation about EOE causal foods and some research that he's doing into some possible new testing. We still also have up our EOS Connection 2021 virtual conference. You can still log into the conference, and all APFED members can get in for free. And friendly tip, APFED membership is free. So you can be able to get a free membership and get into the conference for free. We do also have paid membership options available with additional benefits, but for more great presentations like Elizabeth's today, please feel free to log into the conference. You can go to apfed.org/conference to access that information. Please feel free to contact us at mail@apfed.org, and please once again join me in thanking Elizabeth for today's presentation. Have a great day, everyone.